Okay, let's unpack this. Welcome to the deep dive, and today we're doing something a little different. A rigorous journal club, really, designed for you, our colleagues in endocrinology.
And not just endocrinology, I think anyone who manages these cases, ophthalmologists, oculoplastic surgeons, even dedicated primary care docs, will find this critical.
Absolutely. Thyroid eye disease, or TED, is one of those conditions where the landscape has just shifted so dramatically. Staying current isn't really optional.
It's not. It completely dictates patient outcomes now, especially with the move from, broad immunosuppression to these highly targeted biologic therapies.
Which is exactly why we're anchoring our discussion today in a really timely review. It's titled Thyroid Eye Disease, What's the Latest?
Right. This was in the Cleveland Clinic Journal of Medicine, volume 92, number 11, from November of 2025.
The team was led by first author Ashley B. Vincent, D.O., along with Christian Esser, Christian Engelman, and Catherine Huang.
And they've done just an invaluable service here, I think. It's a synthesis of the new pathophysiology, the clinical risk factors, and most importantly, a practical guide to the latest treatments. It's an essential snapshot.
So our mission is to extract those core knowledge nuggets. We're going to get into the evolving protocols, the cost-benefit realities of the new biologics, and why that multidisciplinary approach is just non-negotiable now.
It's really about giving you a fast track to the current standard of care. It's funny, the authors touch on this. The disease has roots going back maybe even to Avicenna over 1,000 years ago.
Wow.
But effective, targeted management, that's a very, very recent victory. So today we want to get into the why behind the disease and what these new therapies really mean long-term.
Okay, so let's start where they do, with how we even define TED today. Because what's fascinating is how much that definition has broadened.
Yeah.
It's not just about classic Graves' hyperthyroidism anymore.
That is such a key distinction. The review is explicit. TED is an autoimmune inflammatory condition that, yes, is linked to Graves, but you also see it in patients who are euthyroid or even hypothyroid.
So the takeaway for the clinician is that a history of Graves or, say, high TSH receptor antibodies should always keep your index of suspicion high, no matter what their TSH is doing right now.
Exactly. The epidemiological link is still powerful, of course. The prevalence in North American Graves patients is about 27%.
And it's that 18-month timeline that really stands out. 85% of patients who get TED develop it within 18 months of their Graves diagnosis. That's our window.
That's our surveillance window, absolutely. But to intervene in that window, you have to understand the engine driving the disease. And the authors confirm that engine is the orbital fibroblast.
Let's get into that. How did our understanding evolve from just this general idea of autoimmune inflammation to this really precise receptor-driven model?
Well, the core mechanism is this pathological cycle of inflammation and then remodeling of the orbital tissue.
Which gives us the signs we see in the clinic.
Right. The enlargement of the extraocular muscles, the expansion of the fat and connective tissue behind the eye. And the key effector cells, the real players here, are the CD34 plus fibroblasts.
And it's important to clarify, these aren't just local cells that are already in the orbit. The review notes they're actually derived from circulating fibrocytes.
Correct. They're recruited from the bloodstream,
Yeah.
and their activation brings us to this critical receptor synergy that's really unlocked the new therapies. So the orbital fibroblasts in TED patients, they express TSH receptors. We've known that.
But that wasn't the whole story.
Not at all. The critical piece of the puzzle is this dramatic overexpression of the insulin-like growth factor 1 receptor, the IGF-1 receptor.
And it's not just on the fibroblast.
No, it's on B cells, it's on T cells. It creates this systemic inflammatory potential. So it's not just the TSH receptor antibodies causing damage. It's the synergy between the TSH receptor and the IGF-1 receptor acting as a functional complex.
A functional complex. I like that term.
That's what it is. And activating that complex is the signal that facilitates this aggressive infiltration of fibroblasts into the orbit. Once they're there and they're activated, the whole pathogenic cascade just takes off.
So let's break down that cascade. This is really where the disease process kicks into high gear. What are these activated fibroblasts actually doing?
Okay, so first, they start pumping out inflammatory cytokines, especially interleukin-16 or IL-16.
And IL-16 is a chemoattractant, right? It calls in more troops.
Exactly. It draws in more T lymphocytes, amplifying the whole autoimmune response. Second, and this is huge for the clinical swelling, you get massive hyaluronan production.
Hyaluronan, or hyaluronic acid, which is incredibly hydrophilic. It just soaks up water.
It soaks up water, so when it builds up in that confined orbital space, it draws in huge amounts of water, causing the edema that drives the proptosis and the compression.
And then you get the longer-term changes.
Right. You get increased adipogenesis, so the fat compartment literally expands. And finally, the cells release chemokines that lead to the differentiation into scar-forming myofibroblasts.
And that's the end game, the fibrosis.
That's the fibrotic, often irreversible stage. So that whole sequence, inflammation, edema, fat expansion, and scarring it, explains the entire clinical course of the disease.
And understanding that functional receptor complex is really the bedrock of why teprotumumab was developed. We're not just throwing steroids at general inflammation anymore. We're targeting the engine.
Precisely.
Okay, so if the fibroblast is the engine, what's the accelerant? Let's move on to risk factors. The review does a great job breaking this down into what we can and can't change, which is so important for patient counseling.
It's essential for prevention, especially in that 18-month window. Let's start with the non-modifiable factors.
Things we can't change.
Right. First, age. There's a really consistent peak in incidence between ages 50 and 59, so a new Graves' diagnosis in that age bracket should raise your antenna.
Okay. And sex.
Well, TED is more common in females overall, but the authors really emphasize this. The more severe disease course consistently happens in males. They often need more aggressive, earlier intervention.
That's a critical distinction. It means you probably need a lower threshold for referral for your male patients.
You absolutely do. And third, there's racial and ethnic variation. The highest prevalence is in Black individuals, then white, then Asian and Hispanic individuals.
And the thinking there is that it might be linked to just basic differences in orbital anatomy, like the amount of space available to accommodate swelling.
That seems to be the leading theory. The disease mechanism is the same, but the clinical expression might be modulated by these inherent anatomical factors.
All right, let's pivot to the modifiable risks. This is where the endocrinologist's intervention can truly change a patient's trajectory. And the review is, let's say, unambiguous about the single greatest factor here.
B, the most important modifiable risk factor, smoking. It's a risk multiplier, full stop.
A triple threat.
It is. It increases the initial risk, it's strongly associated with a more severe course, and it's linked to a decreased or delayed response to basically every treatment we have.
What's the mechanism there? What is smoking actually doing to the orbit?
The main theory is that it causes tissue hypoxia and generates a huge amount of reactive oxygen species, ROS. Those ROS just exacerbate the inflammatory environment. And, critically, the data suggests that current smoking is a greater risk than cumulative pack year history.
Which means immediate cessation is the single most impactful thing we can offer. It's not about long-term risk. It's about now.
It is. Now, the second major modifiable risk, and one we are directly responsible for, is treatment-related risk. Radioactive iodine, or RAI.
RAI, this is a big one. It's known to increase the risk of developing new TED, and it can definitely worsen pre-existing disease.
Right, in the months right after treatment. And the mechanism there goes back to the autoimmune process. When you damage the thyroid gland with radiation, you get this surge of thyroid antigens released into the circulation.
And that antigenic load just spills over and flares up the shared autoimmune process in the orbit.
Exactly, which is why we have to be so careful about who we recommend it for. The review is clear on the high-risk subgroup.
So who gets the big red flag?
Smokers, for one. Patients with pre-existing mild TED, anyone with very high TSI levels, the thyroid-stimulating immunoglobulins, or high TSH receptor antibody levels, and of course, patients with uncontrolled severe hyperthyroidism at the time of treatment.
And for those high-risk patients, if you absolutely have to use RAI, prophylaxis is mandatory.
Mandatory. The recommendation is firm. Immunosuppression with glucocorticoids given either concurrently or right after RAI to prevent or treat that flare. It has to be part of the plan.
That's a clear clinical takeaway. Okay, what about the two emerging factors the review mentioned? Selenium and lipids.
So first, selenium. This seems to be a geographically dependent risk. Selenium deficiency may increase the risk or worsen TED. This is really relevant in places like parts of Europe or Asia where the diet is less selenium-rich.
And in North America.
The benefit is much less clear. Our diets are often selenium sufficient, so supplementation is kind of a low risk and maybe low reward intervention for truly mild disease.
Okay, and the second one was lipids and statins. This was fascinating.
It really is. So high total and LDL cholesterol are seen in TED patients, but what's interesting is the inverse correlation. Patients who already have hypercholesterolemia and are on statins seem to have a decreased risk of developing TED.
Which is counterintuitive. Is the mechanism clear? Is it the anti-inflammatory effect of the statin, or is it related to the cholesterol itself?
It's not clear. And the review doesn't say we should be screening all Grace patients' lipids now. It's more of an interesting association. We don't know if statins would be an effective treatment on their own, but it's an area for future research.
All right, let's move on to the clinical trajectory. Understanding the natural course is so important for managing patient expectations. The old Rundle and Wilson description from 1945 is still the framework.
It is, and the course is broken into 3 phases, but the duration is incredibly variable and, again, heavily influenced by smoking status.
The first, and the one most critical for medical intervention, is the active inflammatory phase.
This is the period of progressive inflammation, the tissue expansion. It can last anywhere from 6 months to, 36 months, or even longer in smokers. This is when the CAS score is high and our medical therapies are most likely to work.
Then you hit the static phase.
Which is often just a brief plateau where things slow down but haven't really quieted yet.
And finally, the inactive fibrotic phase.
Right. This is usually 18 to 24 months after onset. The inflammation is gone, and while you might see some slow improvement, this is where the permanent symptoms from the scarring and remodeling really persist. The proptosis, the muscle restriction.
And we can't forget recurrence. The paper cites a rate of almost 16%, mostly within the first 10 years. So long-term surveillance is necessary.
Absolutely. Now, let's talk about the common presentation. What brings the patient in? Most cases are bilateral, but asymmetry can really confuse the picture.
The prevalence data is helpful here. Eyelid retraction and proptosis are the 2 most common signs, both around 57%.
And then you get the functional complaints. Diplopia from the restricted muscles, periorbital edema, redness, severe dry eye, tearing, photophobia, eye pain.
Okay, now we need to talk about the emergency. The one thing that demands immediate, urgent intervention. Sight-threatening TED, specifically dysthyroid optic neuropathy, or DAWN.
DAWN is the most severe manifestation. It only happens in about 5% of TED patients, but we have to emphasize the urgency because the vision loss can be permanent and very, very rapid.
And the mechanism is basically mechanical, right?
It is. It's compression of the optic nerve at the orbital apex, the tightest spot, because of the massive swelling of the extraocular muscles. Less commonly, it can be caused by the nerve actually being stretched from extreme proptosis.
So who are screening most aggressively for DAWN?
The risk factors are increasing age, male sex, and heavy smoking, again. And the authors also highlighted patients with type 1 diabetes.
What's the link with type 1 diabetes?
It's thought to be related to the coexisting diabetic vasculopathy. It compromises the microcirculation to the optic nerve, making it way more susceptible to ischemic injury when it gets compressed.
So we have to know the initial symptoms. If a patient calls with these, they need an immediate referral.
The first are functional. Reduced visual acuity, any change in color vision, which you can test with pseudoisochromatic plates, the presence of an afferent pupillary defect, or APD, and finally, any confirmed visual field loss.
And imaging in these cases would show that classic apical crowding where the muscles are just strangling the nerve.
Exactly.
Which brings us to diagnostics. So imaging isn't mandatory for every single case of classic bilateral TED.
Right. If the diagnosis is clinically obvious, you might not need it, but you should definitely consider it for unilateral or very asymmetric cases, for pre-op planning, or like we just said, to assess for apical crowding if you suspect DAWN.
So let's compare the modalities. CT versus MRI.
Non-contrast CT of the orbits is still the go-to first modality. It's cheap, it's available, and it's essential for surgical planning for decompression. It shows you the tissue expansion very clearly.
But MRI gives you more detail on the soft tissues. It can distinguish active inflammation from chronic fibrosis.
Exactly. On T2-weighted images, active inflammation will light up. It will show high signal intensity. Chronic fibrotic muscle shows low signal. And that distinction is vital for timing your medical therapy.
Okay, let's reiterate the key diagnostic feature on imaging, the radiographic pearl that really confirms TED.
This is the single most important thing to look for. In TED, the extraocular muscle enlargement is fusiform, meaning it's big in the belly of the muscle, and the tendons are explicitly not involved. The swelling stops before the tendon inserts on the globe.
And there's that predictable order of involvement too, right? The I'm SLO mnemonic.
I'm SLOO, yeah. Inferior rectus first, then medial, superior, and lateral. It's a very helpful pattern.
So what else looks like TED? Excluding the mimics is so important before you start someone on high-dose steroids or a $300,000 biologic.
It's critical. The differential is broad infectious, inflammatory, malignant. Let's run through the key ones. First, Orbital myositis.
How does that differ?
Myositis is typically acute, painful, and unilateral. TED is more insidious. The challenge is that myositis also responds to steroids, so a therapeutic response doesn't help you differentiate. Imaging can, though myositis often involves the whole muscle, including the tendon.
Next, the true infection.
Orbital cellulitis, a real emergency. Rapid onset, swelling, fever, pain. This requires immediate IV antibiotics, not immunosuppression.
Then you have the systemic inflammatory mimics, like IgG4-related orbital disease.
Right. IG4-RID presents with bilateral proptosis and swelling of the eyelids and lacrimal glands. But critically, severe visual disturbance and pain are uncommon, which helps differentiate it. Diagnosis usually requires a biopsy and checking serum IgG4 levels.
And finally, the really scary ones, lymphoma and that catch-all term, pseudotumor.
Lymphoma is the most common malignancy of the orbit. It can be insidious, unilateral, or bilateral proptosis. You need a biopsy. As for pseudotumor or nonspecific orbital inflammation,
A diagnosis of exclusion.
it is. And the key differentiating factor on imaging, again, is tendon involvement. If the tendon is inflamed, it's highly suggestive of nonspecific orbital inflammation, not classic TED.
Okay, this is a perfect pivot to the core of this deep dive treatment. The for you is clear. You need an individualized approach based on disease activity, the COS score,
Yeah.
and severity, the you-go-go classification.
Right. The CAS score tells you if you should intervene medically. A score of 3 or higher out of the 7 signs means the disease is active and likely responsive to immunosuppression.
And the you-go-go severity classification tells you how aggressively to treat.
Correct. It's in 3 tiers. Mild, which is minimal impact. Moderate to severe, which is enough impact to justify intervention, think significant lid retraction or constant diplopia. And then sight-threatening, which is Dan or corneal breakdown.
Before we get to the heavy-hitting drugs, let's just reiterate the foundational management for every single patient.
First and foremost, achieve and maintain euthyroidism. It stabilizes and can improve TED. But, and this is a big but, anti-thyroid drugs or thyroidectomy alone do not alter the course of mild TED.
Now, local treatments.
Non-negotiable. Artificial tears, gels, taping the eyelids at night, elevating the head of the bed, and of course, immediate smoking cessation counseling.
Okay, so for true mild TED, what's the specific medical treatment?
You add a single 6-month course of sodium selenite, 100 micrograms, twice a day.
And it's limited to 6 months because of toxicity concerns, but what about the efficacy debate in the U.S.?
Well, the benefit is mostly shown in selenium-deficient populations. Here in North America, the marginal benefit is probably lower, but it's a low-risk intervention for true mild disease.
All right, let's get into the main event. Moderate to severe active TED.
Okay, so IV glucocorticoids are the traditional first-line therapy here, especially for active disease without a ton of soft tissue involvement, so more inflammation and pain than proptosis and diplopia.
The standard regimen being IV methylprednisolone, 500 milligrams weekly for 6 weeks, then 250 weekly for another 6.
And it's potent. It improves the CAS score in about 77% of patients. But its effect on proptosis and diplopia is much less robust, and you have to watch out for adverse effects from that high cumulative dose.
Which brings us to the game changer, teprotumumab.
Teprotumumab, the anti-IGF-1 receptor antibody. This is for active, moderate to severe TED, especially when you do have that significant soft tissue involvement. The proptosis and diplopia where steroids often fail.
The results from the OPTIC trial were just extraordinary.
They redefined expectations. 83% of patients on teprotumumab had a proptosis reduction of 2 millimeters or more, compared to 10% in the placebo group. The number needed to treat was 1.36.
It's just incredible. But now we have to talk about the elephant in the room. The cost. Roughly $360,000 in 2023. How are clinicians even navigating that?
With great difficulty. It requires meticulous documentation of disease activity CAS of 4 or higher, proptosis of 3 millimeters or more, to justify it over IV steroids. Many payers require you to fail steroids first.
And let's talk about the long-term response. An NNT of 1.36 is amazing, but if the sustained response rate is only around 33%, isn't that a bit misleading?
That is the exact challenge we're facing now. We get these spectacular acute results, but about 2/3 of patients may relapse or fail to maintain that initial improvement. One study found 24% needed retreatment.
Was retreatment successful?
Yes, encouragingly. The Opatagus extension study showed that about 62% of patients who flared did respond to a second course. But of course, that adds to the enormous cost burden.
Okay, let's drill down on the adverse effects, because the endocrinologist is on the front line of managing these. Let's start with hyperglycemia.
This is a major one. The mechanism is fascinating. When you block the IGF-1 receptor, you reduce the negative feedback on growth hormone secretion. So GH goes up, and that causes hepatic insulin resistance and increased glucose output.
So for our diabetic patients, you basically have to preemptively adjust their insulin?
You do. Aggressive monitoring is key, and doses often need significant upfront adjustment. And for non-diabetic patients, you have to screen for new onset diabetes throughout the course.
And the second big side effect requires bringing in an audiologist.
Hearing loss occurs in up to 10% of patients. The theory is that IGF-1 is important for inner ear hair cell survival. Block it, and you diminish that pro-survival signal.
So baseline audiograms are mandatory.
Absolutely mandatory. The good news is that about 65% of those who have hearing loss return to baseline after they stop the drug. But it's a serious potential side effect.
All right, what about other options for patients who fail or can't tolerate IV steroids? Let's talk about rituximab.
Rituximab, the anti-CD20 antibody, it depletes B cells. It has shown some efficacy in decreasing the CAS score in patients who were previously treated with steroids and failed.
But not in treatment-naive patients.
Correct. And it has very little effect on proptosis or diplopia, so if soft tissue involvement is the main problem, rituximab is not your drug.
Okay, what about tocilizumab, the IL-6 receptor blocker?
The evidence here is a bit conflicting. One RCT failed to show benefit, but a real-world study was much more positive. It's generally reserved for patients who are intolerant or non-responsive to IV steroids.
Now, the review also highlights a really interesting split in global consensus on mycophenolate mofetil, or MMF. This is a great journal club point.
It is. The studies on MMF, either alone or with IV steroids, showed some favorable trends. It helped reduce the steroid burden and maybe even relapses.
And this led to a split in the guidelines.
Exactly. UAGOGO, the European group, recommends MMF combined with IV steroids as a first-line therapy because they weighted that steroid-sparing effect and reduced relapse rate very heavily.
But the American and European thyroid associations disagreed.
Right. The ATITA task force felt the data wasn't convincing enough, especially on proptosis improvement, to make it a first-line recommendation. So this is where clinical judgment really comes into play.
And finally, orbital radiation therapy, or ORT.
This is an old tool. It works by depleting lymphocytes and fibrocytes. It's often used as an adjuvant with steroids, and one study showed it had a favorable effect on motility and helped prevent dawn in active disease.
But you have to be careful who you use it in.
Absolutely. It's contraindicated in patients under 35, and it's a relative contraindication in patients with severe hypertension or diabetes because of the risk of retinopathy.
Okay, let's shift to the emergency. When a patient has dawn, the protocols change completely.
Immediate intervention is non-negotiable. First line is high-dose IV pulse steroids.
What's the regimen?
500 to 1,000 milligrams of IV methylprednisolone daily for 3 days. It's an aggressive pulse to bring the inflammation down fast.
And if that doesn't work, or if the cause is nerve stretching from proptosis?
Then you need urgent orbital decompression surgery. It provides immediate relief of the pressure. And it's the required first-line treatment for nerve stretching, which rarely responds to medical therapy alone.
Even after decompression, they might still need other therapies.
Oh, yes. They often need adjuvant medical therapy, or ORT, to fully inactivate the disease and prevent progression.
Okay, so once the acute phase is over, we move to surgical rehabilitation. And the timing here is just, it's everything.
It cannot be overstressed. You only do surgery during the active phase for sight-threatening emergencies. Otherwise, you risk a massive flare-up.
So the rule is, the disease must be quiescent for 4 to 6 months, and the patient has to be euthyroid.
If you don't meet those conditions, the risk of a poor outcome is just too high. It's a marathon, not a sprint.
And there's a rigid surgical sequence that has to be followed.
A sequence that anatomy will not forgive you for violating. First, if needed, is orbital decompression to treat the proptosis. That stabilizes the globe's position.
Then what?
Then, strabismus surgery to correct the alignment and diplopia. You can't finalize alignment until the orbital volume is stable.
And last?
Last is eyelid position adjustment. Lowering a retracted eyelid, raising a ptotic one. The eyelid position depends entirely on where the globe ends up, so it has to be the final step.
And this whole complex process really underscores the need for one thing above all else.
The multidisciplinary imperative. It requires seamless collaboration. Primary care, endocrinology, ophthalmology, neuro-ophthalmology, oculoplastics. Established teams have been shown to improve time to diagnosis and treatment.
And the shared goal is to maintain euthyroidism, manage the risks of therapy, and collectively decide on the right intervention at the right time, using CAS and UGOGO as the common language.
And you need support rules, too. Audiologists are now mandatory partners for teprotumumab, smoking cessation clinics, and often psychologists, given the profound impact of this disease on a patient's life.
This has been a really comprehensive deep dive. We've covered the shift in understanding TED from just a Graves' complication to this complex receptor-driven process.
We've hammered home the modifiable risk factor smoking and detailed that stratified treatment approach, from selenium for mild disease to the novel but complex biologics for moderate to severe disease.
We really emphasize the profile of teprotumumab, its incredible efficacy, balanced against the cost, the side effects like hyperglycemia and hearing loss, and that real risk of reactivation.
And if we connect this to the bigger picture, the development of drugs like teprotumumab is proof that we understand the pathophysiology so much better. But the cost, the risk profile, and that long-term response rate hovering around 1/3, it all suggests we have significant challenges ahead.
Which brings us to our final provocative thought, one the authors themselves raised, and one that you, the specialist, will be wrestling with in the coming years.
The question is this: when we use an aggressive, short course of a targeted biologic, are we truly reversing the disease course, or are we just interrupting it?
Is the disease just picking up where it left off once the drug is gone?
That's what that 33% long-term efficacy rate might suggest. So should we learn from immunology and maybe shift our paradigm? Think about continuous low-dose treatment.
So smaller doses, given more frequently, but for a much longer time.
Maybe for years. Could that lead to more sustained remission and mitigate some of that relapse risk? You have to consider the implications of chronic, low-dose IGF-1R inhibition versus the high-intensity short-course protocols we have now. That fundamental question about how we achieve sustained, lifelong remission, that remains wide open.